I have been a colorectal surgeon for about 40 years now in practice. I went into colorectal surgery because I wanted a domain where I have a lot of opportunity to do a lot of things, not being limited to 2-3 procedures. And the beauty of this field is that in a week period, we can do a ton of illnesses and pathologies, whether from the abdomen or in rectal, open, laparoscopic, robotic, and lately, over the past few years, dealing with fecal incontinence and the newer modality and the newer methods of working up those patients in a more scientific way than in the past. So that's why I became a colorectal surgeon, and I don't regret a single day. Throughout the years, the way we have been working out people with fecal incontinence is, at the beginning, we were doing a lot of dietary management, management with medication, anti-motility agent, bulking agent, etc. But those benefits are pretty limited. So then we had the option of doing surgery with repair of the anal sphincter, which gives good result, however, not sustainable over many years. Luckily, over the past few years, I discovered the sacral neuromodulation, which had been previously been used for fecal incontinence, and we applied to the fecal incontinence with outstanding results, honestly, and especially that those results are sustainable, so they don't decrease in effectiveness with time. They stay pretty much permanent. After meeting with the patient, and the most important thing is to find out the reason for the patient incontinence. So that patient could be young, could be old, and there's different pathology, different etiology for their condition. So if it is something that is obstetric, then obviously, and a young patient, then obviously surgical reconstruction of the sphincter, at some point it is advisable. However, all those patients, we work them up with, of course, a thorough physical exam and history taking, which gives us really most of the clues about what the patient needs will be. But then we substantiate that in a more scientific way, in a more objective way, by doing rectal testing in the office and checking the pudendal nerve to see if there's anything that discordant from what the physical findings are. And once we determine the exact cause and what is the best way, then most of the time, I would say, especially over 50 years of age, sacral neuromodulation probably is the best approach for those people. So I discuss with the patient the pros and cons. I discuss, of course, all the workup needed and all the results. Once we do all the testing, we sit down and I give the patient the pros and cons of different approaches and the benefit of the sacral neuromodulation. So, and I tell them, I show them the instrument and the different instruments that are available, different sizes, etc. And I tell them that there is a testing phase that we do in the office under local to see whether they're really going to benefit from the implant later on. And then they do monitor that over the next 10 days. And then 10 days later, we do the implant in the operating room. So they know everything about from the first day, before they even venture to have the local anesthesia in the office and the local procedure, what we call P&E. And I have the patient also record their fecal incontinence before surgery and also after. And one thing I would like to say about, especially about the company that I'm dealing with, Axonics, is that what I was really surprised and happily surprised is the amazing support team that I have around me to help the patient with questions, with answer to their to anything that they may have to ask them. The support team is amazing. It makes the whole difference as far as post-operative care.